So it's my pleasure and honor to welcome Dr. Sachin Jain as our next keynote speaker. Dr. Jain is currently Senior Advisor to the Administrator for the Center for Medicare and Medicaid Services, also known as CMS. And in this role, he works closely with Dr. Berwick in executing his agenda with a special emphasis on the launch of the Center for Medicare and Medicaid Innovation, also called the Innovation Center at CMS. So just a few months ago, as you may know, prior to joining CMS, Dr. Jain was Special Assistant to the National Coordinator for Health Information Technology, working closely with Dr. Blumenthal. And just a few other points of Dr. Jain's background. He has his training from Harvard, bachelor's, MD, and MBA, residency training at Brigham and Women's Hospital, so is a board-certified internal medicine physician, but also, as you know, prolific in writing, and he's co-edited a book called The Soul of a Doctor, published in 2006. So we're really excited to hear Dr. Jain's presentation and comments about what's happening currently in innovation at CMS, as well as just his experience with the Office of the National Coordinator. So please join me in welcoming Dr. Sachin Jain. Thank you for that.
Thank you so much. Anytime I give a talk, I always look at the schedule and I kind of mark out where I am related to lunch. So I am totally aware that I am what stands between you and lunch. So hopefully I'll make it worthwhile and interesting for you. I think I have one of the best jobs in the country right now. I had the opportunity to work with Dr. Blumenthal on executing his health IT agenda. I now get to work with Don Berwick, who, if any of you have gotten to know at all over the past several years, is just, I think, one of the true visionaries in American healthcare. And I get to work on on implementing two of the most important pieces of legislation that I think the healthcare industry has seen over the past 20 or 30 years, really since the passage since the creation of Medicare and Medicaid in the 60s. I literally almost every day wake up with this just incredible feeling of excitement that I have an opportunity to do something good, because I think that the legislation that I reference really offers us that opportunity in just the most profound way. As a clinician, as a patient, as a citizen of this country, I just think that the work that's going on right now to change healthcare delivery is really just really exciting and is finally moving us in the direction that we want to move. I think there was this profound sense of lack of hope in this country around the healthcare system because people didn't have access to care and because the system of care, to most of us who've spent any time with it, just feels grossly unsustainable. The amount of waste that happens, the fact that the delivery model is just so broken, I think is really it's depressing, frankly, when you work in a system that doesn't work well, when you get care in a system that doesn't work well. It really leaves us wondering what we're all doing this work for. So I think the passage of the HITECH Act and then subsequently the passage of the Affordable Care Act has really given me a lot of hope, and I hope that you all share my enthusiasm for some of the changes that are taking place right now. Before I get too far into the details of what we're doing at the Innovation Center and what's been happening in our National Health IT agenda, I want to talk with you a little bit about some of the work I did before I went to work for the administration. Before I worked for the administration, I was a physician, but I also was a member of the faculty at Harvard Business School, where I got to work on studying innovative models of healthcare delivery. And it was just, it was amazing to be able to interact with tens and hundreds of people around the country who were trying to do innovative work to improve healthcare delivery. Some of them right here in the backyard of this hotel, right here in Philadelphia. Over the course of a few years of work, I got to know a group of pediatric oncologists in Texas who were using Health IT to make sure that every single patient that they saw had access to a multidisciplinary treatment planning approach. And they used Health IT to actually leverage and create that system, not because any payment system actually told them that they needed to do that, but because they thought it was the right thing to do for their patients. I got to talk with Jim Stevens, who was the chief medical officer here at CHOP, and learn about the network form of organization that they were trying to create, and using Health IT to actually make available the tremendous tertiary and quaternary care that's available at CHOP to a broader array of patients and to a broader population throughout the Philadelphia and Philadelphia metropolitan region. And in getting to interface with people who are actually doing innovation in healthcare, you realize that we're an industry. Healthcare is an industry that is fundamentally full of just absolutely talented people who are trying to do the right thing every day. And it's amazing to me that some of that hope and some of the enthusiasm that they actually bring to work actually persists in the face of a regulatory and payment environment that does everything it possibly can to stifle that enthusiasm. So I think it's really a testament to the people who actually work in healthcare that they're able to kind of persist through some of the challenges that they face in actually innovating in the face of payment systems that treat us and treat clinicians and treat patients like they're all the same. And I think any of us who spend any time in healthcare know that that's actually really not the case. So I want to share a few reflections from this work and from these interactions with people on the front lines of healthcare innovation. The first observation I want to share, and I think that this is something that CMS today respects very deeply. And you may not think so, you may not believe it, but CMS truly believes that that real innovation happens on the front lines of care delivery. It doesn't happen in Washington, it doesn't happen in Baltimore, it doesn't happen in policy journals, it doesn't happen in business schools, it doesn't happen in medical schools, not in insurance companies. It happens very intimately at the interface of patients and clinicians. That's where we learn how to do our job better. And it happens when well-intentioned people on the front lines identify a problem, recognize a need, and do something about it. The second observation that I want to make is that we have the greatest, I think, opportunities for innovation exist at the interface of a tension between standardization and customization. We have a healthcare system that is truly designed to take care of what I call the median patient. And I think this median patient is really mysterious to me because in all my clinical work, I've never met the median patient. In sort of interacting with friends and family, I've never met someone who identifies themselves as the median patient. And I think that this orientation towards a median patient is at the heart of so much of so many of our problems that exist in the American healthcare system. Our sickest patients, our most complex patients, the patients in greatest need of our help are routine in their non-routineness. Yet our system of payment tries to create neat boxes for patients to reside in. Even our efforts to improve quality presume or assume a median patient. And so I think at the same time we have a system that doesn't act in a reliable way with any sort of reliability. And so I think that the greatest opportunities to innovate in healthcare today exist at this interface between this tension between wanting to standardize, wanting to introduce real tight operations management to the delivery of clinical medicine, and the need to actually to customize it to the needs of individual patients and groups of patients. My third observation is that, and I think I've reflected on this already a little bit, but I kind of want to underscore it out of real deference to everyone in the room who I think understands what I'm talking about here, is that innovation in healthcare, for better or for worse, has been what I think of as really a Sisyphean struggle. I get this image sometimes of someone standing on a mountain trying to push a boulder, big boulder, 5 or 6 times their size, up the mountain, and then all of a sudden, the slope just gets higher. And that, I think, is what the world of innovation is like in healthcare. I don't think that the actual work of delivering great care to patients is in terms of actually figuring out what we need to do to take great care of patients is actually that challenging. I don't think that innovation in healthcare is actually rocket science. We tend to think of it as rocket science, but I really don't think it is. I think it's the payment models and their inherent inflexibility that make it feel that way sometimes. Right here in your backyard, you have an innovative healthcare system in CHOP that is probably doing things to improve healthcare delivery, not because they get paid more for it, but because it's the right thing to do for their patients. And we too often rely on the nightly intentions of people in the healthcare system to actually do what's right. I'm always reminded of Duke University's efforts to actually improve cardiovascular care for patients with heart failure. Any of you who have known anyone with heart failure or have taken care of anyone with heart failure know that actually taking care of patients with heart failure is not that challenging. You have to manage their diet really well, you have to make sure their diuretics regimen is appropriate, and you have to monitor them really closely to make sure that they don't go out of a narrow window of where they actually get in trouble. So Duke University, recognizing this, said, we could actually avoid a lot of these hospital admissions that are happening because ultimately we could take better care of these patients as outpatients. And so they went about to implement a really terrific heart failure management program that was so successful that one day the chief of cardiology got a phone call from Ralph Snyderman, who's the CEO of the hospital, and he said, "What's going on in our heart failure admissions? They're going down, we're losing money." That's the system we have today. Doing what's right for patients doesn't always pay. These patients had better outcomes, fewer hospitalizations, lower total cost of care, but it didn't matter because the bottom line was suffering. So winning clinically, keeping patients out of the hospital, healthier, safer, to all of our frustration, has historically not paid. And for every true service innovator that I've ever actually met in healthcare, I've heard exactly the same frustration when I try to push on, why we haven't been able to sustain some of the improvements that we've all demonstrated at some point in our clinical practice. And they say health plans or CMS don't want to actually talk to us about new models of payment or care delivery. The best phone call I've had over the past year was an oncologist from New Mexico. She was just terrific. She called me up and she said, "I have a model of oncology care that keeps my neutropenic patients out of the hospital longer." Neutropenic patients have, for the non-clinicians in the room, these are people with really low blood counts. She said, these patients are the sickest patients in the hospital. They can die on a dime if you expose them to the bugs that exist within a hospital and you don't give them the right medications. And she said to me, "I've created a medical home, for oncology patients where I'm able to keep these patients out of the hospital. They come to my office immediately when they get sick. We do everything we can for them in our office, and only if it's absolutely necessary do we send them to the hospital. And I have the mortality data to prove to you that it actually improves care, and I have the cost data to show that I've saved $12 million in cost over the past year. And I went to the local Blue Cross and Blue Shield plan, and I said, can you pay us differently so that way we don't actually have to, we can keep these patients out of the hospital." And she got a pat on the back from them, and they said, "Thanks so much for all your terrific work. We're going to keep paying you the way we pay you." And I can tell you, tens and hundreds of stories like this, of people who know the right thing to do, who try to do the right thing, and ultimately fail in the process because the system doesn't really support it. So now this is the point in the speech where I break out and I say, I'm here from the government and I'm here to help. Okay. So I've painted a grim picture, and we're all feeling really depressed right now. I certainly am. And I want to argue, though, I'm going to go back to some of the enthusiasm in which I started my presentation today, which is I think we have a ray of hope. I really do. I think we have a new opportunity to actually change the way we pay for health care. I think it started with the passage of the HITECH Act with $27 billion in new incentives that you all know about for the broad and meaningful use of health IT. I think that the connectivity that allows is going to actually push a lot of improvements in healthcare that we could have gotten 20 or 30 years ago, but it's really never too late. And it's continued with the Affordable Care Act, which many of us see as a bill to improve access. And I think one of the criticisms that I used to make about the Affordable Care Act before I actually got into the hard work of actually implementing it, is that it's a bill that changes our coverage, but it doesn't do anything to really change the delivery system. And I felt that way until I read about Section 3021. Anyone here know about Section 3021? Anyone a real healthcare geek out there? I got one. Any other geeks out there? All right, so how many of you have heard of the Innovation Center? Okay, a few more geeks out there. So Section 3021 is the part of the legislation that actually creates the Innovation Center, the Center for Medicare and Medicaid Innovation. And so the big problem that I've defined, when this oncologist in New Mexico goes to the payer and says, we're not going to pay you any differently, part of the reason that they're not going to pay her any differently is because, and part of the reason folks don't want to change when even one payer starts to actually pay them differently for their care is because Medicare and Medicaid have never really been flexible in how they interface with providers. It's basically one deal that they offer providers. This is how we pay for things, and payment, for better or for worse, actually shapes delivery. And at best, you might have been able to approach CMS and say to them, we've got this demo that we want to do, and if your congressman calls them and your senator calls, then one day, perhaps you would have a demo. The whole world changed with the passage of Section 3021. Section 3021, in establishing the Innovation Center, creates a $10 billion new government agency that is charged with testing and scaling new models of payment and delivery that improve quality and reduce costs. That's the mandate of the Innovation Center. And so, okay, $10 billion sounds like a lot, but in a multi-trillion-dollar industry, it's nothing, right? But the magic of this Innovation Center, and I don't use the word magic lightly. None of you here really know me, but magic to me is something that's really special. The magic of the Innovation Center is that the Secretary has the ability to take any model, Secretary of Health and Human Services has the ability to take any model that improves quality and reduce costs and scale it to the entire Medicare and Medicaid program. So all of a sudden, all these orphan interventions that we all know will improve the health care of our country, the health care of our communities, actually have an opportunity to potentially get paid for. When I was in medical school, I read about a trial that many of you may be familiar with called the Diabetes Prevention Program. This was a multi-center, 27-center study of about 3,000 diabetics. Can you guys tweet about the fly that's buzzing around me too? This was a 27-center trial of 3,000 diabetics that assigned them to a placebo arm, a metformin arm, and a lifestyle intervention arm that basically demonstrated that we could prevent progression of pre-diabetics to diabetes if we either gave them metformin or a lifestyle intervention. And in fact, the lifestyle intervention actually worked better. And when I read this in medical school, I said, holy cow, every South Asian person I know now has hope of not getting diabetes, because if you know South Asian people, they actually have diabetes in large numbers. And lo and behold, this has turned into a national epidemic. We've got millions and millions of more people now who are obese, who are at risk for diabetes, and we actually have an intervention that we've tested that now 10 years later we know still persists in its effectiveness. Both metformin and the lifestyle intervention 10 years later shows a persistent reduction in diabetes rates. But we've never had a payment model that actually supported it. So instead, what happens is that folks who are doing this work continue to do an NIH funded research, hoping that one day someone's going to pay attention, that one day some of this stuff is going to find its way into clinical practice, that someone's going to actually care that they had an intervention that's based on a delivery model, not a drug, on a delivery model that actually saved lives. But they never ever had a mode to actually implement that intervention because there was never a payment model to support it. Well, today there is. The Innovation Center actually gives us an opportunity to take the findings from that study, test them with a Medicare population, and actually scale it to the entire country. And so I did some back-of-the-envelope calculations on the DPP last weekend. And the average, I'm just going to bore you with some math for a second because I think it's fascinating. The average excess healthcare expenditure for a diabetic over a non-diabetic, in a matched cohort is about $6,000 per year. $6,000 per year. And if you actually, apply the diabetes prevention program, this study of, that basically applies to about 10 million Americans, to that total population. You could, if you actually follow the numbers through, of the study through to completion, save about 3 million cases of diabetes annually. If you were to save 3 million cases of diabetes annually, and you were to take the $6,000 in excess healthcare expenditure that you're saving, you've got $18 billion in healthcare savings right there. The cost of the intervention is about $3,000 per patient, just delivered over the lifetime of the intervention. So for a $20 billion intervention, roughly, you basically have the opportunity to save $18 billion per year. I mean, it's amazing the way the math works. But the truth is that we've all already known this. It's just we never had the policy apparatus to actually support it. Well, I'm here to tell you that we actually do, that the Innovation Center actually gives us an opportunity to really change healthcare delivery and scale that which we know works to the entire population of Medicare and Medicaid beneficiaries. So, what is this Innovation Center going to focus on? I mean, so the truth is, I think that I both love the word innovation and I hate the word innovation, because everybody sees what they want to see in the word innovation. It means it's one of those words that actually kind of means it's kind of lost its meaning. So we've tried to define it, and we've tried to define some areas of focus. And so the 3 areas of focus are, number 1, patient care model. So patient care model. For any population, for any disease condition, we know how to we need to find better ways to actually take care of diabetics, of patients with heart failure, of patients with asthma, of patients who have premature births that result in long NICU stays. There are opportunities to innovate along the care model. And so we want to invest significant resources in actually testing and scaling new models focused on specific conditions and specific populations. The second area of work sort of acknowledges the fact that if you have a system that works perfectly well to take care of individual patients and individual conditions, you don't have a perfect system. Rick Gilfillan, this is the point in the presentation where Rick Gilfillan, who's the director of the Innovation Center, actually makes all of you stand up. So I might actually see what this is like, and try it out with you guys. He's done this in rooms of 1,000 people. Stand up with me, please. And you'll remember this, hopefully. So Rick talks about this notion that we've got a highly fragmented healthcare system. So start your hands over here. And we want to take our highly fragmented healthcare system and move it over to a seamless system. And I don't know what that hand wave is really all about, but you guys, the truth is you can sit down. That was great, thank you. So we've got anybody, a few of us were talking before we got here. We've got this highly fragmented healthcare system where we've got individual doctors and individual clinicians, nurses, who are doing the very best that they can to take care of individual patients. But the system itself is so fragmented in how it functions because information doesn't flow, because we have very few sort of real coordinating mechanisms across the healthcare system, that our model of actually fixing this problem is we throw people at it, we throw money at it, or we just let it actually persist in the way that it is. So Rick talks about this notion, I'm going to do it with you now, of fragmented care to seamless care, and that's really what we want to do. We want to take the system that exists in all these different pieces and try to bring it together. And so some of the work that's coming out of the Innovation Center will focus on accountable care organizations, on medical homes, and other new delivery models that are actually going to try to assemble care around patients, around populations, and make it actually, not lost on us is the importance of actually trying to make the act of being a clinician more rewarding for people and more personally satisfying, because we know that the system of care, in addition to being frustrating for patients, is actually really frustrating for the folks who actually make it work against all odds, which is frontline healthcare providers. The third area of work is really revolutionary for CMS, which is community and population health. Don Berwick, when he got to CMS, the first thing he did was he rewrote the mission statement to include this notion of actually improving population health. That CMS would actually take responsibility for the public's health because it has such an important stake in it. And so, we want to determine ways that we could use payment policy to actually drive massive improvements in major public health problems. So take for example the issue of cardiovascular mortality. If we just did what we already know works in the healthcare system reliably, effectively, in a standardized way, but also customized to the specific needs of individual patients, we could save 1 million lives a year. We really could. If every patient who needed to take aspirin took aspirin, if every patient who needed to take a beta blocker took a beta blocker, and every patient who needed to take an ACE inhibitor took an ACE inhibitor, we could save literally tens and hundreds of thousands of lives. We've never had a delivery system that's actually tried to do this, that's actually tried to treat this as a separate problem. And so the Innovation Center is here to actually say that we are going to care about those things. And we're going to try to change the way that CMS does business around population health issues. So a lot of people were really excited about the HITECH Act because it actually gave credit to health IT for the first time as an important national priority. But as I think about the HITECH Act and I think about the sustainability of our investments in health IT, $27 billion is not a lot. And I know Ross Copella is in the room, and the systems that we have right now are not terrific. And so how do we actually think about creating a sustainable model for investments in information technology and informatics? I think if we get the payment models right, and we focus ourselves on the right kinds of outcomes, not on volume, but on value, and focusing on actually improving patient and population health, all of a sudden it will make intuitive sense to a CEO of a hospital to invest in health information technology. It's not going to be the stuff of the geek squad anymore. It's going to be the stuff of the C-suite in the hospital. Because ultimately, health information technology will be seen as a driver of operational improvement, of quality improvement, which will then hopefully lead to improvements in the bottom line. So now, I hope I've excited you. Folks look like they're getting hungry, but I do hope that I've excited you about the Innovation Center. The question now is usually, so how do we interface with the Innovation Center? We're still figuring out our business model, and we're still figuring out our authorities. I mean, Congress will write 2 pages of legislation, and then we go about the hard work of actually trying to figure out how to do right by the mandate that they gave us. And so, I'll tell you a little bit about how we're going to work. And I frame this in terms of what I call the 7 doors. Disney had the 7 dwarves. The Innovation Center is going to have the 7 doors. The first door, it's a terrible joke, I know. The first door is sort of government work is progress, which is request for proposals. We've got a couple of priority items. The legislation lists a couple of priority items. We're going to put out a solicitation. Folks will respond to it. We'll get tests up and running. We'll do some program implementation. We'll do some evaluation. And then programs that work will hopefully come to scale. The second area of work is what we're calling Medicare modernization. And you'll see there's overlap among these doors, but I think that they actually provide some conceptual clarity. The second area is what we call Medicare modernization. There is stuff that we do on the front lines because of the way Medicare and Medicaid pay for healthcare that is just not logical. So I'll give you a couple of examples. So Medicare is the only payer that doesn't pay for home infusion. So when we want to do an infusion for a patient, we actually admit them to the hospital. It's goofy. As a resident, it's like your nightmare admission, or depending on how you look at your job, it's either a sweetheart admission or a nightmare admission, because you're just basically booking some paperwork to get this patient an infusion of drug because of how we pay for things. So we want to do a rapid test of home infusion to basically be able to figure out can Medicare save money and improve quality by paying for home infusion. We suspect that we will be able to do that. Another example is Medicare requires a 3-day admission to the hospital before placement to rehab facilities. Something that any of us who practice medicine think is not necessarily a great use of resources or a great use of a hospital bed. Something else that we might test. So Medicare modernization is what we're calling door 2. The third area, and this is where I would encourage you to actually go home today and send us an email with your idea, is what we're is basically our portfolio selection process. It's what I call crowdsourcing, what James Surowiecki called crowdsourcing, what I'm stealing from Surowiecki, crowdsourcing. which is this idea that the best ideas for improving healthcare come from you guys, and the best ideas for payment innovations will come from you all. And so tell us what they are. We're going to take those ideas, take the very best ideas, and then use those to actually structure things through door one, the request for proposals. And so if there's a problem that you think we need to solve, or if there's a solution that you think you have to a problem that you think needs solving, tell us about it. Because ultimately, we are very humble about the fact that we don't have all the answers. We don't know all the ways that we're going to be able to improve care and reduce costs. The fourth door is sort of a very rare door, which is kind of like the unsolicited proposal, which is you've got an idea that is so unique, and you're an organization that's so uniquely capable of executing on it that we'll do a sole source, non-competitive contract with you. We don't anticipate actually doing this, but in any great frequency, but I'll give you an example of an organization that might qualify for that. The American Board of Medical Specialties is a very unique organization. They are the only umbrella organization of medical specialty organizations. They might be able to apply to us for a unique funding program because they are unique in their charge. There's very few organizations that actually fit that mandate, but we do want to have that opportunity to sort of provide a sole source contract when it's called upon. The fifth is what we're calling prizes and challenges. We want to be able to take a problem that we want to solve and go to all of you and say, solve it for us, and come back to us with your best results about quality and cost, so that way we can scale it and that we can actually start to implement some of those ideas out in the universe. And this is something that we haven't fully conceptualized yet, but something that's pretty, I think, promising for its opportunities to actually seed innovation throughout the country. Door 6 is what I call the evidence-based door. So I think there's a few very specific examples of where CMS already knows that something is going to reduce quality, is going to improve quality and reduce costs. Where the test has already been done, where the study has already been done, the evidence has already been collected. And all we really need to do is package that evidence and hand it to the Secretary and say, Madam Secretary, we've got this amazing intervention that's going to improve the quality of healthcare in this country. Please use it to change policy in this country. And so we're still working with our lawyers to clarify exactly how that authority is going to work and whether the legislation truly contains that authority. But you can imagine how promising that actually might be. And door 7 is what we're calling test networks, which is we want to have some contracted relationships with organizations that are ready to test things in rapid cycle as they come up. We don't want to necessarily have to go to the market every time we have an idea that we want to test. We want to have some organizations that are ready with the evaluation capabilities, the implementation capabilities, to actually do the test for us so that way we can get data quickly and use it to drive changes in policy. So I hope I've been able to convey to you that the sort of sense of depression around innovation in healthcare. What I call sort of the feeling that you need to apply for a grant for everything that's going to improve quality and reduce costs. I'm hoping that that's going to go away in American healthcare, because we will hopefully have a business model in a few years where we're going to reward you for doing what's right for patients consistently, and that you'll go to work every day excited about finding opportunities to actually improve care and improve the quality of care that we deliver to Medicare and Medicaid beneficiaries. So I thank you very much for putting up with my shenanigans, and would love to take questions from the audience. Thank you.